Welcome, everybody. It's good to see you, and I'm sorry we're starting just a little bit late, but we are thrilled to be together today. I'm Andy Rich. I'm the Dean of the Colin Powell School, and it is my pleasure to welcome you to this, which is our 10th annual Sternberg Family Lecture. I welcome everybody who's here with us in the room, and a big welcome to those who are watching us over the live stream. Today is very special because it does mark a full decade of doing this lecture, an event that has become one of the most important for our campus community every year. Over the years, our subjects have been climate change, international affairs, the health of our democracy, the state of higher education, and the immigrant experience. There are three things that I think the Sternberg lectures have had in common year after year. First, these are lectures on complex, timely, and unsettled subjects. They're on topics that engage all sectors and all people, young and old, and they require the efforts of all of us to improve things. Second, these are lectures on subjects that cannot be reduced politically to a simple Republican or Democratic, conservative or progressive solution. We focus on topics that require engagement and efforts across the political spectrum. And then three, these are lectures on subjects that matter to us here on this campus, to our students, to our faculty, and our staff. On all of these fronts, our subject today could not be more on point: healing our rifts, a vision for health justice. And we celebrate this first decade of this very special lecture with a very special speaker. Dr. Dave Chokshi, who delivers the 10th annual Sternberg Family Lecture, is also the inaugural Sternberg Family Professor of Leadership. Dr. Chokshi joined CCNY in this new endowed professorship last fall. Before that, he served as the 43rd Commissioner at the New York City Department of Health and Mental Hygiene, one of the leading health agencies in the world. Dave led the city's response to the COVID-19 pandemic, including its historic campaign to vaccinate more than 6 million New Yorkers. During the pandemic, Dave led efforts to design and implement testing and treatment strategies, to navigate school and economic reopenings, and as many of you who will recognize him from TV will recall, he served as the city's principal public spokesperson. His prior professional experience spans the sectors, private, public, and nonprofit. Since 2014, he has seen patients at Bellevue Hospital and continues to do that one day a week. He trained in internal medicine at Brigham and Women's Hospital in Boston. I mention it because that happens to be where I was born. And he was a clinical fellow at Harvard Medical School. He earned his MD at the University of Pennsylvania, and he has degrees in public health from Oxford, a bachelor's from Duke. Before I turn it over to Dave, I want to extend my sincere thanks to Cy and Lori Sternberg, who are with us here today and who have made all of this possible. Cy Sternberg graduated from CCNY in 1965, and he has never stopped giving back to his alma mater. For many years, Cy was the chairman and the CEO of the New York Life Insurance Company. During his tenure there, the company set up what still to this day is the largest endowment at the Colin Powell School and one of the largest at the college, focused on supporting students and leaders working on emerging African-American issues. Cy is a member of the Board of Visitors of the Colin Powell School. He's also a member of the board of the Foundation for City College. He's not only an exemplar of what this place can do for young people, he's also, frankly, one of its biggest cheerleaders and its supporters. This lecture, Dave's professorship, are made possible by the Sternberg family. Please join me in thanking them for their generosity. Thank you. Dave is going to speak for about 35 to 40 minutes, and then maybe 40 to 45 minutes, and then we're going to have time for Q&A. At the end of today's event, we're going to be joined for closing remarks by Vince Boudreau, the president of City College. He is listening to the event now as he makes his way back from Albany, where he is making the case for CCNY and CUNY to legislatures. He should be with us well before the end to close out today's event. Thanks again for being here. Dave, let me turn it over to you.
Thank you so much for that warm introduction, Andy. And it's really an honor to be delivering the 10th annual Sternberg Family Lecture in Public Scholarship. I want to add my deep gratitude to Cy and Lori Sternberg for this venue. and also for their support of my joining the faculty of the Colin Powell School and City College. I say very sincerely, it's a great privilege. As Dean Rich mentioned, I am a primary care doctor. And in primary care, we have a word for eking out tiny, incremental changes. We call it success. Accompanying a patient to get that MRI they've been fearing, or convincing them to take their blood pressure pills, or to cut down from 6 cigarettes a day to 3, these are all legitimate cause for celebration. But by the end of my talk, I hope to convince you that in these times, incrementalism is not enough. As we reflect on the 4-year anniversary of the COVID-19 pandemic, a seismic event that resulted in unfathomable loss and human suffering, our times call for bolder change. If the pandemic were an earthquake, we must examine the tectonic plates underlying that suffering. Poverty, racism, tribalism, and the lack of trust, social cohesion, and human connection across communities. We require fresh approaches and different ways of organizing groups for purpose, particularly groups spanning different lived experiences and generational boundaries. Essential to this project are new leaders who are able to imagine and forge connections across seemingly disparate or siloed realms. For all of the students here, let me be very clear. I'm talking about you. In a nutshell, that multi-generational and transdisciplinary approach to leadership is why I was so excited to join the Colin Powell School last year. Broader trends, from our stagnating life expectancy to eroding economic opportunity, also demand that leadership for robust responses and creative coalitions from every sector of society. Even before the pandemic, this graph shows that there were about 16 million uniquely American birthdays lost compared to peer nations. If you look at the darker line on the top, that represents our actual reality here in the United States. The y-axis is years of life lost in millions, and the x-axis marks the passage of time. The lighter line at the bottom represents what that would look like if the United States had the same mortality rates as our peer high-income nations. And the difference in 2019, before COVID-19, was 16 million uniquely American birthdays lost. For those of us who care deeply about health, we should feel this. We should feel it because it's happening on our watch. And each of us should hear about this preventable suffering and feel the hairs on the back of our necks rise, a stiffening of our spines. But look, it's a little too easy for me from behind this lectern to say that bold leadership is needed. What's harder is to chart out precisely, tangibly, how to do this amidst congressional gridlock, backlash against racial justice priorities, the Supreme Court setting back reproductive health by a generation, and measles outbreaks cropping up around the nation because life-saving vaccines have become associated with partisan identities. Yes, this is harder. I certainly don't have all the answers, but here are a couple of frames that I hope move us in the right direction. To describe the first, let me start by sharing that in each office that I've inhabited over the past decade, I have a whiteboard that I inscribe with 3 columns: short, medium, and long, as in short term, medium term, and long term. I try to allocate my tasks and priorities across those three categories. This helps me make sure that I'm dedicating time to those things that are important and not just urgent. In the same way, I believe that moving to health justice, a world in which every person has what they need to experience well-being, a world in which every person has what they need to experience well-being, requires grappling with what I think of as three dialectics. In some cases, these are false dichotomies. In others, just tensions or spectrums. But reconciling them is what I mean when I refer to healing our rifts. And they roughly fall along a short-term, medium-term, and long-term prioritization. These three dialectics will serve as a scaffold for the rest of my remarks. But before spending a little bit of time on each, I have one more point that I'd like to try to make. Some of you will recognize this emblematic photograph from the pandemic. For me, it represents the other half of what we are forgetting in our collective amnesia about COVID-19. Not just the tragedy and the suffering, which ought to be honored in a meaningful way, but also the heroism captured in this hug. The way that false barriers to progress melted away in the heat of a crisis, whether it was standing up the largest vaccination campaign in our city's history or cutting child poverty in half nationally. We have to remember and channel that sense of will, that volition. Now, let me spend a little bit of time on each of my three dialectics before we open it up into a conversation. The first is healthcare versus public health. And look, when I think about this from the perspective of one of my patients, it must seem almost bizarre. What do you mean healthcare and public health don't already work well together? Shouldn't they just work things out behind the scenes? And isn't my health their common goal? But the truth is, these two parts of our health system are often siloed with dramatic consequences. I have a bit of a personal vantage point on this because part of the reason that I was asked to serve as health commissioner in the summer of 2020 was to help mend the rift between the public healthcare system, where I had been for 6 years, and the health department, which I was being asked to lead. Some of you may remember that responsibility for contact tracing was assigned to the hospital system rather than to the health department. This led to discord that played out on the front pages of the newspaper that summer. And putting myself back in the shoes of my patient, this is not exactly what you'd want to see happen between healthcare and public health during a once-in-a-generation pandemic. On the flip side, it is remarkable what we can accomplish when the two halves actually work together as a coherent whole. This is a classic diagram. It was originally published in 1961 and then updated in 2001, and I think it's the best argument about what could be. If you just start at the top left of the diagram, there are 1,000 people in the community, a given 1,000 people, and they're asked about their health experiences over the past month. And you see how it winnows down. About 800 report symptoms in the past month. A little bit over 300 consider seeking medical care, so on and so forth, until you get to the 13 that visit an emergency department, 8 of whom are hospitalized, and less than 1 who is hospitalized in a specialty medical center. But our resources and our dialogue about health is too often concentrated in these tiny squares at the bottom right. If we care about the health of populations, we of course have to look beyond clinics and hospitals. In those settings, when I'm taking care of patients in my clinic or making rounds in the hospital, we talk about seeing patients. But we have to pay particular attention to what I think of as the patients we do not see, whether because of access barriers or cost or fear, and the forces of marginalization that contribute to their not crossing our threshold in the first place. The stakes for bridging these silos are always higher for people who are low income or otherwise marginalized. A great, albeit sad, example is the opportunity we have to eliminate hepatitis C because of curative medicines made available over a decade ago now. Not many people realize that hepatitis C is an entirely curable disease, yet less than a third of patients receive timely treatment in the United States, in the richest nation in the history of nations. This is because we don't have consistent partnerships operationalized between healthcare and public health. These partnerships would help ensure patients are not lost to follow-up and help patients rapidly access affordable treatment. We should be curing hepatitis C en masse right now. Instead, we see the sequelae of our failure to do so in our ICUs, there in the bottom right-hand corner of the diagram. Our patients, too often delirious and bleeding as their own livers fail. But I promised you that in this talk, I would not just focus on quote unquote admiring the problem, but lift up real world solutions. In the case of bridging healthcare and public health, we caught a glimpse of those solutions during the pandemic because we saw the artificial walls separating the two tumble down. There's simply no way we would have been able to vaccinate over 6 million New Yorkers in just over a year without deep partnership across hospitals, health insurance and health departments, clinics and community-based organizations, and physicians and pharmacists. We now have a chance to cement that approach into business as usual. And that's why last fall, we created something called the Common Health Coalition, which I have the privilege of chairing. I'll say a little bit more about it, but first, here's a short video about why it was founded.
Here's a secret you might not know. Healthcare and public health are two critical pieces of America's health system that, believe it or not, haven't always worked consistently together. But during the height of the COVID-19 pandemic, saving lives meant having to work hand in hand. In many places across the country, the arbitrary walls that kept the two fields divided disappeared seemingly overnight. This unified, de-siloed health system should be our new normal. Instead, we are seeing the opposite. Walls are being rebuilt and life-saving innovations left behind. There is a future in which those hard-learned lessons from the pandemic aren't forgotten, but instead are identified, amplified, and replicated across the country. That's why we created the Common Health Coalition. 5 leading American healthcare organizations have banded together under one banner for the first time with a clear purpose: to pursue a reimagined health system, one in which public health and healthcare work hand in hand to save lives and prevent suffering. A common goal, an uncommon approach. Join us at commonhealthcoalition.org.
If the pandemic has taught us anything, it is that the best preparation for public health emergencies of tomorrow is improving the health of the public today. Another way of thinking about this is that we must choose action over amnesia. The Common Health Coalition is trying to ignite that spark. I'm proud to say that 2 weeks ago, we made an announcement in Washington, D.C. about how the 5 founding organizations are coming together, as you heard, for the first time to strengthen partnership with public health. They are demonstrating leadership not just by doing what so often happens in Washington, D.C., issuing recommendations, but by making commitments and taking specific action. Our coalition believes that this work has historically suffered from a poverty of implementation, not of ideas. So we're not interested in another report that will sit on a shelf, but instead to spark change at a national scale, particularly by state and local leaders. Here's a little bit more on the substance of what we're trying to do. These span 6 shared commitments made by those 5 founding organizations across the 4 focus areas that are listed here. I won't read them out to you, but instead underscore that all of them are in pursuit of that mission, that singular common goal, our health, through an uncommon approach, which is represented by 33 concrete actions that these organizations are taking across these focus areas. Each of our founding members has identified actions within each commitment that their organizations will take, and we're calling on healthcare and public health organizations across the country to join us. Now, we'll see what the response is across the nation, but something that gives me hope is that throughout American history, leaders have stood up in the aftermath of disasters and committed to honoring the past by investing for the future. I think about what happened in New York City after 9/11, particularly the example of NYPD and FDNY, which took a hard look at their own protocols and the way that they were working with one another during that catastrophe, and pledged to work across their own silos in ways that have benefited New Yorkers during Superstorm Sandy and so many emergencies since then. In the same way, we have a chance to weave together public health and healthcare delivery with the shared experience of COVID-19 as our stitching. The second dialectic that I'll spend a few minutes on is health versus the economy. During the pandemic, I also saw how public health and the economy could be pitted against each other. And there were some times when tough decisions did indeed have to be made. These photos capture essential workers during the spring of 2020. For me, they bring to mind one of my own primary care patients who asked me in May of that year, after that devastating first wave, when I thought the lockdown would end. A Colombian father of 3, he worked in a restaurant and was growingly worried about money for food and rent. I remember feeling troubled. Since he had high blood pressure and kidney disease, he was at higher risk for poor outcomes and more likely to get infected because of his job. But the economics of the lockdown, of course, brought its own challenges, particularly for his mental health. But we must remember that more often, health and the economy are not a zero-sum equation. In fact, we also saw during the pandemic how our entire economy is linked to a sufficient standard of health. Vaccination helped bring back our economy and our schools over the course of 2021. I'll never forget seeing a school gymnasium through the shining eyes of my wife, an educator who herself came up in Queens public schools. She remembered frolicking and playing in the gym, simple joys unavailable to her own students for several months. And the heightened anxiety around COVID reminded her of the everyday miracle of school, where parents entrust what we hold dearest in the world, our child, to a stranger. Of course, they're not actually strangers. My wife recalled a colleague kneeling down to embrace her student on their first day back in class. The teacher and the child had both lost their fathers to COVID, but in the teacher's words, I at least had my father for 35 years. She only had hers for 11. The pandemic, for everything it tore apart through grief and loss, also showed the commonality underpinning community. And it was through that lens that my wife saw the gymnasium transformed, PE teachers replaced by nurses vaccinating her students' family members, as well as our own family. Just by rolling up their sleeves, they too were entrusting their life to a stranger, or better said, a neighbor. But despite the miracle of vaccination, we witness profoundly unequal suffering in New York City and across the world. I thought of it as the catastrophic combustibility of an infectious disease with historical patterns of injustice. Even after closing the gap in vaccination rates between Black and white New Yorkers by the end of 2021, we saw that the hospitalization rate for our Black neighbors was more than twice that of whites during the Omicron wave. This diagram is from an early 2022 report by the health department that asked simply, why? And of course, it shows the long arm and the pernicious reach of structural racism. Now, what I tell the students in my class here at City College is to really get to the bottom of racial inequities like this one, we must go deeper. And I derive inspiration from my 4.5-year-old daughter on this topic, who asks why, not once, not twice, or even 3 times, but a further succession still. To elucidate the root causes of racial inequities, we must ask ourselves, why did some non-white populations develop severe disease and die from COVID-19 at higher rates than whites? Underlying health conditions undoubtedly play a role, but why are there higher rates of hypertension, diabetes, and obesity in communities of color? The answer does not lie in biology. Structural and environmental factors such as disinvestment, discrimination, and disinformation underlie a greater burden of these diseases in communities of color. Together, these are the forces that have resulted in those millions of birthdays lost each year in the United States, as well as shocking and persistent inequities in life expectancy, sometimes a decade or more, for Native Americans, Black Americans, and low-income Americans. And the most significant why may be, why are these widespread inequities allowed to persist? We must keep in mind that inequities are disparities that are avoidable, unjust, and unfair. Inequities are disparities that are avoidable, unjust, and unfair. Answering this last why, taking on the formidable issues in the orange box here, like the racial wealth gap, and actually redressing those inequities requires a different approach to the health versus economy dialectic. I've been working on trying to chart a different path forward, a roadmap for change through a nascent health and political economy project. 2 key collaborators on this are Professor Derek Hamilton at the New School, a global leader in efforts to shape a moral economy, and Dr. Victor Roy, a physician, sociologist, and researcher currently at Yale. I'll just briefly summarize the thesis that we've been developing here and then move on to more of the so what. So here's a little bit on our thesis. The prevailing economic paradigm has for several decades given primacy to free market thinking underpinned by cultural narratives of individualism and deservingness that infuse our political discourse. This paradigm, which is sometimes described as neoliberalism, has become a kind of common sense, to channel Gramsci, shaping the contours of our society akin to how the laws of gravity shape the contours and the curvature of space-time. Yet, our argument is that the economy is anything but natural. Rather, the economy is inherently intertwined with politics, social group stratification by identities such as race, gender, and national origin, and the norms and interests of those that ostensibly benefit from the existing order. The iterative relationship among these, known as political economy, has profound implications for the well-being of individuals and society. And so any reckoning with our stagnating life expectancy and the gaping inequities in health outcomes we have discussed must take a health and political economy lens, we argue. So what would a new common sense for health look like? We've conceptualized 3 initial areas of focus: capital, care, and culture, captured in this slide. Capital refers to alternative approaches to financing health, such as public health bonds, nonprofit pharmaceutical manufacturing, and market-shaping mechanisms. And the thread as a whole will focus on the quality, scale, and directionality of finance needed for health goals. Care refers to the specific policies and service delivery models that build a stronger care infrastructure across the life course. Proposals for local, state, or federal government include community health worker programs, unconditional cash allowances, tax policies to reduce child poverty, caregiver support, and universal healthcare options. And culture refers to changing hearts and minds about the mutual links between health and the economy. A particular emphasis will be placed on the development of displacing narratives to supplant the existing narratives, such as zero-sum progress, where the advancement of one group is necessarily tied to the hindrance of another. Or as the writer Chimamanda Ngozi Adichie has said, stories have been used to dispossess and to malign, but stories can also be used to empower and to humanize. Stories can break the dignity of a people, but stories can also repair that broken dignity. We're just at the very beginning of this work and will officially launch the Health and Political Economy Project at an event at the New School next week. So I hope some of you will stay tuned for more. Well, believe it or not, the Health and Political Economy Project only represents the medium-term priority using my whiteboard rubric. I hope you're ready to really take a long view with me, because it's the long view that I think is needed to more fundamentally get at the tectonic plates I had mentioned, like tribalism and polarization, which in turn help us jump the ruts of our status quo toward more seismic change. And by way of preface, many of the ideas that I'll discuss in this last segment were developed with my wife, Melissa Aguirre, as part of an essay we're incubating called America Needs a Children's Party. Amidst the cacophony of catastrophes last year, from wildfires to wars, the startling historic rise in American infant mortality, despite it being here on the front page of the Times, barely registered in American consciousness. More of our babies are dying than before, for the first time in over 20 years. Melissa and I were perhaps more attuned than most, given our backgrounds as an educator and a doctor, but also because we welcomed our second daughter last summer. On the day she was born, smoke blanketed the skies above American cities, and the Supreme Court struck down affirmative action. We marveled at her precious new life, awed again by our responsibility for it. Like many parents of newborns, we made few plans those first few weeks beyond feeding and eating, changing, bathing, and sleeping. Repeat. We bathed too in gratitude for our healthy daughters, caring nurses and doctors, and time together to nurture our growing family. Yet the gratitude was tinged with disappointment, a deep disappointment that our family's experience is undoubtedly a privilege. Our news is consumed by talk about inflation and the stock market, abortion, sexuality, who should have certain rights and who shouldn't, the latest indictments and accusations of corruption. Sometimes we forget that our kids are listening, but they always are. And what they hear, we fear, is that they do not matter. While so many have given up on politics, resigned to the dysfunction and gridlock, that choice is not available to children. There is a direct line from our politics to their tenuous mental health and life expectancy. A direct line from our politics to their tenuous mental health and life expectancy. And perhaps traversing that path illuminates a way out of the darkness of our disconnection and polarization. What if the organizing principle of a political movement were the needs of our youngest Americans? Could we scramble our hardened political identities by connecting as parents, grandparents, and guardians? Or what might this year's elections look like if we had a children's party? After having our first child, we remember being more cognizant of our mortality. We wrote our wills and we took a bit more care on the subway. We also thought more about the world we were leaving behind for our daughter. Some Native Americans pose this question as, are we being good ancestors? This challenge makes us consider not just our own children, but the successive generations to come. A children's party would chart an agenda for making us worthy ancestors. Taking this longer lens also refocuses us on the investments that matter more than juicing quarterly earnings. Reams of scientific evidence show the importance of early childhood to future life prospects. Therefore, an advanced economy should not force families to choose between work and nurturing their child. Paid family leave, affordable childcare, and universal preschool would set an entire generation on a different trajectory. As it stands, ours may be the first generation of Americans for whom, as you see here, less than half of our kids will earn more income than their parents. For our family, New York City's universal 3K and pre-K programs have been a lifeline. Each day, we have taken to repeating a mantra when dropping off our daughter to preschool. Be gentle and kind, ask good questions, and have fun. We can take for granted that her excellent teachers will reinforce those lessons while nourishing her body and brain. Yet the contrast with other kids, even in the same city, is stark. We remember encountering one little girl on the train whose pigtails reminded us of our daughter. She had a small purse in her hands and was trying to fix it because the strap had become unclasped. She also carried a pack of Trident in her hands. We looked up and realized she was the daughter of a woman selling gum on the trains. The girl fixed the purse and ran back to her mom so they could get on the next subway car searching for customers. This child's entrepreneurial skills and resilience are undoubtedly assets as she hops from one subway car to the next. But she could further develop language, numeracy skills, social skills, and emotional control, all of which brighten the light she already carries. Consistent childcare could unlock this latent potential with cascading benefits for families across generations. Look, paid family leave, affordable childcare, universal preschool, I know this sounds suspiciously like a Democratic Party platform, but the point is actually to transcend partisan ruts by reshuffling traditional political identities in ways that forge new coalitions and conversations. Is there a more powerful identity than that of a parent, a grandparent, or a caregiver? The stories told by a children's party would be rooted in those identities, and policies would be reframed by leading with their effects on children. Every spasm of gun violence in our country must be met not with thoughts and prayers, but with an invocation of guns' effects on children, since, shockingly, firearm-related injuries are now the leading cause of death for American children. Activating different facets of our identity, meanwhile, must be paired with winning frames. In Philadelphia, a tax on sugary drinks was promoted not as a measure to fight obesity, which may have been resisted as nanny state overreach, but rather to raise revenue for kids programs, including preschools, parks, and libraries. Similarly, massive investment in science, such as research on superconductors, ought to be framed as a way for our children and grandchildren to achieve energy independence and stay globally competitive. In our conversations with more conservative family members, we find our attempts at political persuasion have more purchase when we begin with the lens of our daughters' futures and then extrapolate to the effects on other children. we admit a sort of irony, talking about specific individuals to try to escape the well-worn grooves of our disagreements about individualism. As a nation, we have invested so much in the myth of rugged individualism. We have exported it for centuries, and others have bought into it and hurried to our shores because of it, including our own parents. Individualism also characterizes the American approach to child rearing, the so-called parentocracy, ascribing anything good or bad that befalls a child to parental choices. Yet, American as apple pie individualism is not in our DNA. If anything, we are programmed to seek connection. The cognitive dissonance between expectation, individualism, and intuition, connectedness, requires something to fill the void. The linguist George Lakoff asserts, the biology of empathy allows us to comprehend our connection to each other, to other living things, and to the physical world that supports life. The absence of empathy turns individualism into the isolation at the root of so many of our mental health crises. Any new national narrative must help us make meaning out of our often bewildering lives. America First does this for so many of our countrymen, telling us the story that we need to turn inward to solve our problems, often eliding non-interventionism abroad with xenophobia and white supremacy at home. Long before Donald Trump, America First was the rallying cry for isolationists during both world wars. In this 1941 political cartoon, Dr. Seuss depicted a maternal figure reading Adolf the Wolf to two children, captioned as you see with, "And the wolf chewed up the children and spit out their bones, but those were foreign children, and it didn't really matter." Could Children First displace the prevailing narratives and make tragedies like increasing infant mortality matter more to us? Only if we can knit into our national psyche the notion that we are a country that loves our children, in the sense that Mr. Rogers taught us. Love isn't a state of perfect caring. It is an active noun like struggle. The bipartisan advocacy group First Focus on Children argues that this love is already latent within us, with large majorities of voters supporting a best interests of the child standard that either makes the safety or the protection of children the first priority. You can see here 92% of Democrats and 73% of Republicans. Now we need a new crop of elected leaders to galvanize us by giving voice to this story, particularly younger mothers, fathers, and guardians. So, in conclusion, I titled this talk, Healing Our Rifts, because bridging these three chasms, healthcare versus public health, health versus the economy, and seismic change versus the status quo, feels like the right balance of short-term, medium-term, and long-term, not just on my whiteboard, I hope, but for our world. I'm sure that some of you will have your own prescriptions for what could bring us closer to a world with health and social justice. An antidote to the splintering, the atomization, the centrifugal forces of our society seems like it must be a common thread. I'm so grateful for public dialogues like this one, with thanks again to the Sternberg family for a venue that moves us in that direction. What an honor to get to share some of my thoughts with you today. And now I'm looking forward to your questions and to our conversation. Thank you very much.
We'll open it up and we have a microphone for those who have a question.
Could you share with us what is the latest assessment as the residual COVID activity level? What are we seeing And the second question, what's the likelihood of a second epidemic or a flare-up?
Yeah. Well, I have to preface my answer, Sai, by saying that there were so many times that I made predictions and was wrong. So take what I say with a grain of salt. But COVID-19 was such a formidable enemy for us. But I think because of vaccination, as well as the fact that so many people have had the infection at this point, that it does seem like we are in a categorically different phase when it comes to COVID-19. So I think the chances of us, revisiting the horrors of March and April of 2020 are reasonably low, at this point due to COVID-19. With that said, there are still so many people who remain vulnerable to serious illness. COVID-19, this past season continued to send tens of thousands of our fellow Americans into our hospitals, particularly folks who were older or those with underlying health conditions or with immune compromise. So even as attention to the pandemic has ebbed, we do have to maintain some vigilance and make sure that we're protecting the people who are most in need of protection. I'll interpret the second part of your question maybe in a couple of different ways, which is that I don't see a recrudescence, as I mentioned, of COVID-19 in the same way, but I am very worried that we have not absorbed the lessons of the pandemic that put us on a different footing for whatever the next, health crisis may be, whether it's a respiratory virus like a coronavirus, or even for what I think of as all of the slower moving disasters, the overdose crisis, the epidemic of diabetes and other chronic diseases. All of those things we had, and I would like to believe still have a chance to take what we learned from COVID-19 and set the country on a different track when it comes to being a healthier nation. That remains an unfulfilled project, as you heard from me a bit. And I think ultimately we have to not accept that as a static reality. Thanks for the question.
Hi, I appreciate you being here today. What would you say to the small fraction of clinicians who believe that diversity and DEI efforts have no place in medical education, training, and practice?
Yeah, well, this is part of the backlash against racial justice priorities, that I mentioned in my remarks. And I think that medicine and health provide some of the most stark, real-world examples of what the adverse consequences of not focusing on equity can be. By which I mean, we know from the highest level of scientific evidence, randomized controlled trials, that racial and ethnic concordance, training more Black doctors, training, more Native American nurses and other clinicians is something that saves lives. And this makes sense given how much of our health is tied back to trust, and for so many communities that have been historically marginalized, distrust that reverberates over generations. So that's all to say, I think that health equity, and particularly equity as we think about it within clinical practice, if we're serious about population health, if we're serious about addressing stagnating life expectancy and closing the gaps that are inequities, not disparities, as I mentioned, that has to include an approach that encompasses diversity, equity, and inclusion.
I had a question regarding shutting down the schools. So after they shut down the schools, they found, I read in the New York Times, that stress levels of students being in quarantine were similar to stress levels of kids in war-torn countries. And also, as a result of the pandemic and the school at home, we've also seen an increase in young overdose fatalities and young suicide. So in hindsight, do you think that shutting down the schools was the best way to protect our more at-risk population?
Yeah, this is a really important question. We have to be, precise about what we talk about when we consider what happened with schools. Certainly in March and April of 2020, before there was a vaccine, when we had freezer trucks as portable morgues outside of our hospitals, I do think that it was the right decision to prevent further catastrophe by taking drastic steps like, shutting down our schools at that point. In many other places, those shutdowns continued for far longer. In New York City, starting in September of 2020, even though this was before vaccination and there were very steep challenges, for example, in terms of protecting the health and safety of teachers and other staff, the city of New York did start to bring back students, for in-person schooling, although it wasn't, all students at that point. And I think that was the right balance for that time, but we had to take more and more aggressive steps, particularly as we had the benefit of vaccination to bring students back into schools full-time without a remote option. For New York City, Mayor de Blasio is the person who deserves the credit for being very aggressive about trying to bring back students for in-person schooling. And I would say, in hindsight, New York and places around the country perhaps ought to have been even more aggressive in doing so. So there are some lessons learned here. I think the primary one is that it very much depends on the context of what we're seeing in the community as a whole, and the benefits of vaccination give us far more degrees of freedom with respect to what we can do to try to mitigate, some of the effects that you went through in your question, which I think of as the parallel pandemics related to COVID-19. Thank you.
Hi, thank you so much for being here today. My question was about the Health and Political Economy project that you were discussing. I know that you're still going to present that later on, but when thinking about capital and care and culture, do those foundations work in tandem in your project, or is one prioritized more than the other? And if so, what's the justification and reasoning, as these foundations are so interwebbed right now? Like, how do you tackle that?
We see them in the same way. They're inherently interlinked. In the same way that I described the way in which politics and our economy are also interlinked. Our goal in trying to map out those three domains, capital, care, and culture, is to both hold that complexity in what we're trying to accomplish, but then also build in some accountability for specific initiatives within each of those. When we're talking about things, it's easy to stay at a highly theoretical level and not get down to brass tacks about what each of those pieces looks like. And so whether it's a community health worker program in the care domain, or thinking about creating the displacing narratives that I mentioned in the culture domain, this helps us move from the realm of abstraction into the real world.
Hey there. My name is Louis, part of the economics department here at Colin Powell School. So during your long-term goals point of seismic change versus status quo, you mentioned policy change driven by the best interest of a child. All right. So my question is, how can we kind of trust that this will be done right when there is such a political divide, especially when sometimes science is thrown out the window?
Yeah, I mean, the short answer is we can't, right? But I would argue that the way in which things have become growingly partisan in ways that are different, one of the ways that I always describe this when it comes to public health is that I disagree with the characterization that public health became politicized during the pandemic, because I believe that public health has always been political. And I have the dean of the School of Public Health, Ayman El-Mohandes, sitting here to either agree or disagree with that sentiment, but not politicization, but the ways in which science-based decisions became partisan, that was categorically different during the pandemic. And so I think that's the mechanism, that is the force that has to be contended with itself, to think about what are ways to reverse that tide of partisanship. And so that's really what the idea of a best interests of the child standard would, I hope, help us do, to revisit the hardened political identities, the partisan identities that we have found ourselves retreating into, going back into our respective corners, and instead realizing that there is more commonality through things like our relationship to the children that we love in our lives, or other relationships, that allow us to feel the strength of human bonds that don't have to do with the vitriol that characterizes so much of our discourse today.
Wonderful talk. Thank you so much, from a colleague that I respect deeply. I know you believe in that, but I wanted to emphasize it. I think in response to the question posed by one of our students, the area of communications, I think, was perhaps one of the areas of weakness during the pandemic. And in a large consensus report, a global consensus report, including 384 authors from 112 countries, they all agreed that in the next phase of re-energizing this connection between public health and the nation, the area of communication needs to be rethought. Areas of weakness that have been emphasized, including community-based, culturally informed communication vehicles, were somewhat compromised during the pandemic and caused a rift between public health professionals and communities. The other finding, it's still unpublished, but is very important. In a similar study in 23 countries, we looked at trust in science as an important mediator for choosing better choices in health. And looking at our country, 67% of the US population throughout the pandemic, nothing changed, trusted science, which means that a large portion of our society does not trust in science. Almost 40% of Americans have no trust in science. And we found that that was the most important mediator of good choices made during the pandemic. We compared it to losing a family member. Nothing can be more dramatic. And we looked at losing a family member ever versus losing a family member in the last year, and found that losing a family member in the last year was a stronger motivator to vaccination than trust in science. But when you looked at losing a family member in longer than 1 year during the pandemic, trust in science trumped losing a family member over the last 3 years.
Thank you, Ayman, for sharing those findings, and I think particularly for adding the global lens, to what we're talking about. I think, the points about public health communication and what could have been done better, and the linkages to, some of what we've been talking about with respect to trust and distrust, knowing that that is a global phenomenon, is a very important part of diagnosing the problem accurately. Particularly because misinformation and disinformation are global phenomena for us to reckon with as well. So, thank you.
Time for just one more.
Thank you, Dr. Chokshi, for your talk. I had a question about prioritization of competing interests. I think that many of the things that you discussed highlight intersection and how many of the struggles that occur in public health are connected to one another. So as a clinician, as a public health leader, how do you believe prioritization works, and what are some practical tools that you use in order to decide what is at the top of your list in tackling?
Yeah, thank you for the thoughtful question, Nana. I really sort of go back to my roots as a primary care doctor in thinking about how to answer this, because so much of it does distill down to the question of what matters the most to be worthy of and to earn the trust of people that we are charged with serving. And so let me just make it as tangible as I can. When a patient enters into my exam room for the first time and they come in with knee pain as well as a blood pressure over 200, my job is to address the knee pain first if that's why they're seeking care. Because even if the blood pressure is what will kill that patient, I will be more trustworthy if I take care of the issue that they're coming for help with in the first place. And I offer that as a bit of a metaphor, to think about how we need to prioritize in ways that are maybe not always the way that we would think about things technocratically, but really matter, particularly when we're trying to address inequities or change anything that operates on a base of trust or distrust. Always take care of the knee pain first. Thank you. Nice to see you. Nice to see you. Thank you.
Well, let me say, Andy, in introducing this talk, talked about the scope, the 10-year scope of the Sternberg lectures, how deeply felt they've been on this campus, how appreciative we are, Cy and Lori, that you've made this possible for us. This talk, Dave, it was opened up a whole new conversation on campus, and it opens it up not just because you're here as a lecturer, but you're now the inaugural Sternberg family professor in leadership. And so I want you to know that sitting here and listening to you made me so proud that your voice is going to be associated with this college and for what this college stands for. So I want to thank you for those remarks. I want to thank you for the long-term project that you bring to the college as well. As I listened to it, I thought about two things, really. Two things that I think about in relationship to this college all the time. Every year during freshman convocation, I say something to incoming students that we know is true statistically, it's verifiable, that a huge number of the young people sitting in the audience are changing the entire history of their families just by coming to City College and graduating. And because my colleague from another CUNY institution is here, I'd say the same is true across the CUNY system. I might even say that if you weren't sitting here, I'm in. And so your willingness to put in front of this audience a long-term vision, and the remarks you made at the beginning of your talk about the need for new leadership, I think, should resonate with this audience in the way that all the Sternberg lecturers have brought topics that resonate with this audience. The other thing I want to say is that if that's true, if we are that kind of engine for social mobility, And certainly when you talk about the sort of social indicators of healthcare and the deeper structural preconditions for healthcare disparities, social mobility is one of the ways that you can bundle all of them together and work to solve them, to ameliorate them. If that's true of this institution, then it operates not just in the lives of the students that come here. It should operate in the disciplines we teach, across our schools, in our departments, in our classes. We should be thinking about the implications of science, of architecture, of engineering, of the social sciences, as addressing and attacking the barriers to social mobility. That's our brand. And what you've laid out in focusing on the future of children as a political vision, I think is a perfect addition to the City College conversations we have about public policy. So I want to thank you for that. Cy and Lori, another great lecture. Appreciate all your support, and deeply, deeply, deeply appreciate you deepening the lecture support into a professorship. Our ability to have a longer-term relationship with people like Dr. Chokshi is invaluable on this campus, and so thank you very much. Please thank both our speaker, Dr. David Chokshi, and our sponsors, Cy and Lori Sternberg, for another Sternberg lecture.